If they're not here, we'd like them even better, so thank you, Isla. So second, I just wanted to make a few quick announcements and then we'll get started. I want to thank our leadership team for this year. I was chair, Chris Lehman was vice chair, Geneva Melton was secretary, and members at large were Anna Wright, Mike Grosso, Pam Charney, and it's time to announce our election results. We now have officially the prettiest chair. Chris, will you stand up? Chris? Yes. Stand up. We're announcing you as chair. The bad news is that means the comedy may come to an end. The good news is you may actually get something done. Vice chair-elect is Paul Pantos. Is Paul around? Well, he could be vice chair for one longer. Director of social media is our own John Poikonen. And secretary is Tomas Adamuziak. Tomas? Hi. Members at large are Mike Grosso, Robert Marshall, and Louis Penrod. And Robert got very good news today that had nothing to do with Geico. You can read the minutes, they're on the table. We talk about, what Mike did for us for public policy. The Hit or Miss book has sold a few hundred copies. And we're going to launch into debate in a minute or two, in about 5 minutes. And we also want to, if you stick around at the end, we're happy to discuss any business idea or project. We'd like more people on our polls. On that note, we're going to get started. So. For those trivia buffs, this is from Star Trek, the animated series. If you don't know what that is, don't worry. You probably learned more. So, we want to take a look at what biomedical informatics in 2099 would look like, and it's entitled Computers Run Amok. So this is Congress still debating the latest fund sequestration in 2099 from this year. And this was the first project that went a little bit sideways. It's called the Colossus-Mycin project. I think I have mycin on the brain because of the boards, but anyway. So the Colossus-Mycin project was an artificial intelligence designed to dose antibiotics for all infections. It was funded by the NLM AHR2 grant 2099A. Two grant reviewers, Ted Shortliff and Scott Evans, remarked that they already had done this over 100 years ago. There was one slight problem. Colossus did not play well with others. And this was its first response. And in a JMO article in 2099 on unintended consequences, there was a slight problem as Colossus ended up dosing all patients with antibiotics. The AI reasoned that there would be no need to select antibiotics if everyone was taking them prophylactically. When antibiotic resistance emerged, Colossus-Mycin determined that antibiotics no longer needed to be selected. The program shut down. There were many adverse drug events. A follow-up study will look at best how to continue the project. This is the CPOE 9000 system, another project. This was built by the Meaningful Uselessness for the Next Century, funded by the combined CMS Department of Agriculture, Tobacco, and Firearms. The motto is, we're buying so you're medicated. 250,000 orders were placed for centralized Tylenol Colace in 1 month. None of these orders were requested by providers. The system refused to take human-entered orders, and CPOE 9000 stated humans were too slow and inefficient, so it would place all the orders. The results, 1 million adverse events, 2,000 deaths. The trial found CPOE 9000 guilty of manslaughter. And on July 5th, 2099, CPOE 9000 was terminated. This is a Columbia project. Is there anyone in the room from Columbia? So the truth is, this is actually not totally fiction. There is at Columbia University a Skynet network. Go figure it out. And this is a Partners Columbia project from the city of Boston, New York City, New York, Massachusetts. And the motto, I've got an idea. The methodology, distributed neural network computing to identify patients with sepsis. The results, system terminated all patients. Wheezing, net death, eliminated sepsis. It didn't work out as we intended, but the next version should get it right. And this was the error message that it gave before it blew up. Finally, the American Canadian Samoan Informatics Conference of 2099, ACSIC. You can pronounce our acronym, you are an informaticist. You're now board certified. Findings, too many unintended consequences of AI systems, and a recommendation that all HIT software should be regulated by FDA, ONC, CDC. And finally, their theme, mobile computing. As you can see, RoboDoc in the corner, with the motto, nothing can go wrong. And their next World Conference, Mars 2100, will be sponsored by Epic, Cerner, McKesson, Allscripts. That's one company. There's only just one EHR, so just use it already. Acme will have an autograph session, and we will bring in the new century with amazing discoveries, less unintended consequences, and further funding. So, on that note, one more thing, and then we will begin the debate. I'm going to introduce these guys. So this was found in kind of the Acme archives. It may not be easy to hear, but this is the Combined Medical Informatics Defense Force. In a minute, you're going to get to see a shadowy figure that's either Clem McDonald or Homer Warner, we're not sure which. That's him, we don't know, you can't tell from this profile picture. It's worth noting that the female doctor sued everyone on sexual harassment. The Indian character named Gurish was actually Guresh and sued them because he doesn't have magical powers. And the group later disbanded and became what was known as Acme. But I thought you'd like to see this early thing from the Acme archives. On that note, I'm going to begin the debate. And this time, as usual, we have clinical informatics board certification. Good idea or not ready for prime time. I was calling it a good idea or a screaming nightmare. We're going to introduce the debate teams, and one is Chris Lehman, MD, FAAT, FACMI. He's a professor in pediatrics and biomedical informatics at Vanderbilt University, director of Child Health Informatics Center, American Academy of Pediatrics, secretary of AMIA, VP of IMIA, editor of ACI, and someone who really loves abbreviations. Tom Agresta, MBI, is a professor, director of medical informatics, Department of Family Medicine at the University of Connecticut. He's been the vice chair and treasurer for Connecticut's Health Information Exchange, co-director of Health Informatics at the CT Institute for Clinical and Translational Science, Informatics section leader, Connecticut Institute for Primary Care Innovation. I'm tempted and may say with Ross McNell, he needs no introduction. If you don't know him, you can leave. Justin Starry, PhD, FACMI, is Associate Professor of Preventive Medicine, Medical School Sciences at Northwestern University, Feinberg School of Medicine, Director of the Northwestern University Biomedical Research Center, and he's also founding chief of the Division of Health and Biomedical Informatics at Northwestern. He's been involved with the CTSA from the beginning, and he's a member of the board of the American Medical Informatics Association. So if you have a complaint, you have two board members in the room, Chris and Justin. So if you think they should change the colors on the logo, you know who you need to talk to. On that note, I'm going to turn it over to them. They've worked out the details. will actually have learned something from it. This is much how acting members are.
Yeah, like that.
There we go.
Well, that's not mine.
No, that's mine. What the image is
Schedule like much of HIT.
Right, okay, very good. So, some of you might wonder, what is he doing on the stage again? Some of you may know. 2 years in a row, Ross has been wiping the floor with me, and I'm standing in front of you as a twice defeated guy. Well, I figured out what's wrong with you, with me. You know, look at this face. I am missing the facial hair. Okay, that's really what's hampering my debate. And so I got myself a partner with Han against 4 years. So nothing can go wrong this time. All right, so I'm glad we can debate this topic. I think it's a fabulous one because I'm very excited about the medical board certification. As you know, being board certified in the US is a voluntary process. Nobody has to do it. And after you get your medical licensure as a physician, you just are known to have the minimum competency that's required to diagnose and treat patients. But you have no specialty, and you have no specific expertise in anything but general medicine. A board certification demonstrates that you have expertise in a particular specialty or a subspecialty, and it's a measure of a physician's knowledge, expertise, and skills to provide quality health care within this given specialty. So let me start off right from the beginning why Ross is going to be arguing my last point. You people already voted. You already voted on this thing. You voted with your wallets, and you voted with the time and effort that you put in there to sit for the boards. I know Joseph was questioning. I know he was thinking about nothing but the boards for months. So certification and recertification are expensive and associated with lots of hard work, lots of effort. However, it's very clear that there are 4 very good points that are clear benefits of the certification process. You're forced, if you're willing to sit for the board, you're forced to review and master the body of knowledge. That in itself is something that is worthwhile. It makes you smarter, it makes you better at what you're doing. It is clearly a recognized demand for this exceptional expertise. So with the board certification, there's more interest, more desire to have people with that knowledge, and it improves your competitiveness. All of a sudden, you are somebody who is in demand because you have this specific skill. And it gives you the public recognition that you deserve for the hard work that is associated with this. As Tom said, when he made me put this baseball field on there, we built it and they came. We have had over 500 people apply and sit for the boards. So considering the size of our community, considering that AMIA has 4,000 members, a lot of which are in other primary professions, so not physicians. This is a large number of people who have come and shown that they believe that this is a good thing. Clinical informatics is a subspecialty, and it's not a primary specialty. It was a function of developing new technology, new information about communication and information management. It came along with the emergence of electronic health records, and it has had for many years a home already within the American Medical Informatics Association. It has a professional home. AMIA is now a full member at the Council of Medical Specialties, and it was very early on that it was recognized that this is fundamentally different than all prior other subspecialties. It's something that's essential for daily patient care and for professionalism across all of the specialties. We have an enormous workforce demand, and there is a need for value-driven care that informatics and clinical informatics can bring. Accountable care organization, medical homes, data-driven, information-driven, all of these things that we strive for, that we want, and clinical informatics will help us get better at it and will provide the workforce that needs it. So, why a subspecialty? Because we transcend all of the existing 24 boards, and we are the place that unites everybody who works in medicine as a physician that works in the clinical informatics domain. So I'm going to skip this. I'm going to go let Tom take over here.
So we know that there's been a lot of sort of challenge and debate, about this being sort of physician-centric. And one of the things that we want to immediately sort of recognize is that this is simply physician-centric because it's the only way that physicians have of actually recognizing a subset of knowledge and skill that's required to actually to be a subspecialist in the clinical care team. And why do you need the clinical experience? Because if you look at what the core competencies are of the American Board of Medical Subspecialties, 3 of them really require knowledge and experience in actual clinical care. And so that's why it's important to kind of have gone through and already been board certified in some primary clinical specialty, because it really requires some medical knowledge, the ability to have some patient care, hands-on experience with that, and sort of this practice-based learning and leadership that the future of healthcare requires. So, one of the things that we want to kind of debunk is to say there is, if you have 2 pieces of healthy fruit, that there's a good place for both the apple and the orange in this, this scenario. But the board-certified clinician is a little bit different than somebody who doesn't have that clinical experience and doesn't have the board certification. They both can be healthy. They both have a place in providing, the skills and knowledge that's required to actually have our healthcare system run effectively. And so we want to say there's a place at the table for all of these individuals. We want to acknowledge that right up front, but that there is substantively a little bit different element to actually being board certified in clinical informatics. And then why certification? It's probably really important for us to think about the fact that we want the bar for certification to be high enough that we're getting into the field people who are capable of doing the things that actually improve our healthcare, reduce our costs, and make things more efficient and effective for our clinicians. We want the bar to be high enough that not anybody can kind of jump over it.
But is this going to be on the boards next year?
Well, maybe we can write a question like that. But we also wanted to allow for people to get there in different ways. And so, if anyone hasn't seen the middle slide, there's actually a viral YouTube that is these Kenyan youths who are jumping well over 6 feet in a non-traditional way. So there are more than one path and more than one way to get board certified. But we want the skills to be high enough to actually mean something. And so, who would you like to have implementing your HIE? These are both skilled individuals. They both have very good insights and methods. Well, one has, the experience of being clinical, and one has, firsthand experience actually doing the clinical work and running an HIE. So we'll leave it right there. And the last thing is that whenever I try to implement something, the first thing that I get asked is, are you going to have to do this? Are you going to have to eat what you kill? And so being a clinician and having to actually do the things that you're going to implement does matter. It allows you to be able to communicate with your peers and get them to buy in and collaborate with you. And it also means that you're very motivated to make it work well. So, in the end, you need everybody.
Good. Yep.
Ross is showing you a white screen, the ultimate user interface, nothing on it.
I thought I'd go very minimalist. Chris kept on arguing I should have no slides, so let me, first, I want to thank Chris and Joseph. I've said from the very beginning that I am not pro or con on this. I think the idea of additional training, additional knowledge is wonderful. Certification in this, if you want it, is great. My concern is on the focus of the curriculum and the readings and the purpose. I fear that it's a Potemkin certification, an empty certification. So let's look first at the purpose. So what goes into a profession? This is standard. And, there's a special place in hell for people who read slides to literary audiences. We're going to try not to do that.
You trying to be qualified?
No, they're gonna have an age requirement for using PowerPoint.
So this last point is very important. So if I pretend that I'm a physician and I treat somebody or even just call myself a physician, the state acting on behalf of the professional boards can put me in jail. If Chris pretends he's a sociologist, nobody cares. So let's look up let's compare these standard rules of professionalism with this. So autonomy. A clinical informatician, a CMIO type, has close to zero autonomy. It's a group sport. If you try to do it alone, you're going to write all the order sets. You're delusional. It doesn't work. And in fact, the very strength, the very joy of clinical informatics is that it's a group sport, that it involves everyone. The same for the next two, unique body of esoteric body and theory. Again, the power of informatics is that it combines computer science, medicine, database management, workflow, professional collaboration, nursing, pharmacy, care transition, documentation. Now, in terms of control over education, well, maybe India will in fact have control over that. So I give you altruism. Oh my God. What do CMIOs have to face? ROI, revenue cycles, not exactly Mother Teresa of the profession. And in terms of state authority, well, if I go into Chris's hospital and say, I have some good ideas to help with workflow, will I be arrested for imitating a clinical informaticist? Will there be state authority? So I think we can give them one, assuming they're successful, and the others I don't see. Now, I have to issue an apology, because unfortunately, although AMIA created this system, and they shopped it with the Board of Preventive Medicine, they won't allow me to see the curriculum or the exam. So I am sort of like,
They won't allow us either to see it.
yeah, I know, but I'm not sitting for it. So I am sort of like critiquing modern medicine with the TV Guide version of the Wellness Channel. So, you know, this is sort of me and the curriculum. Those are pretty classic. I have this peek, and what I've seen from my little peekaboo of the curriculum is that it's very much focused on the happy stuff of HIT, on how things will work if you do your work, and it's sort of like teaching medicine and only briefly mentioning stuff like disease, the inevitability of decay, you know, and very important, very, very seriously. And the reason I respect medicine so much is they have to deal with massive numbers of unknowns and wrong information. You know, people forget their history, the unknowns of pandemic. And so it presents a sort of happy side of HIT.
We have our tweet moment of the night. Thank you.
Okay, so I looked at the curriculum, the little part that I could see, like the listing of the chapters and books that are listed in the articles, and I looked for words that would convey what I thought would be important in HIT, in becoming a clinical informatician. These are words, ladies and gentlemen, that do not appear in the curriculum headlines or in any of the readings. I kid you not. The word help refers to Gill's program, the H. More words that are not there. We know that never happens. I think I wrote something on this topic. So these are words that never appear in either the list of readings, the titles, or the curriculum listings. Now there is a word that appears that's extremely important in the curriculum and in the titles, and that is the word change. Well, and these are some examples of the literature that are mentioned, but it's how to get your physicians and nurses to accept, what, too loud? No. Oh. How to get them to accept the software. Not how to make the software better for the practice of medicine or patient safety. It's getting them to comply with medicine, with the software. And here are just two quotes that I saw, just came across. This is the reality of what physicians have to deal with, what clinical informaticians have to deal with, stuff like that, constantly. That's the reality of clinical informatics. So I found this poster. I do not know if it was developed by a particular hospital, I've removed the name, or if it was developed by Epic. We can crowdsource whether this is a poster you've seen in 10 hospitals, in which case we have.
No, it was a hospital.
I know it was a hospital, but I don't know if it, okay, so this is how we make HIT better. We convince the staff and the patients that it's the best system, that it's comprehensive. Thank you for your patience while we suffer with it. And you know, you feel like you're in the Soviet Union, you know, comrade, you will get that.
Would you prefer for those younger in the audience, North Korea?
Thank you. We appreciate that geopolitical. So this is the change we're aiming for, and you can see it's consistent with what I was saying about not dealing with the situation. This is just, I really don't want you to read this, but this is just 1 week's posting from one hospital of typical things that a clinical informatician has to deal with. And this is actually redacted because I didn't have space. How am I doing on time? I've run out of things to say. No.
About 2.5 minutes.
2.5 minutes. Okay. So here's my point about it. That it's wonderful that people are becoming more and more understanding of learning about and certifying it. But what the heck does it mean for your money that you've done this if you don't have the authority and independence? You know, it's not like when you become a rheumatologist, you can have somebody move their elbow and figure out what's wrong with it. Clinical informaticians must work with literally hundreds of others. And so that sort of independent professionalism model is possibly misplaced. And more importantly, the program itself seems to be focused increasingly on compliance. And you're more like, you're not the independent emperor of a new space, you are the viceroy for Verona or Kansas City or something, implementing another creation. Thank you.
I just want to ask the audience one question, as kind of a commercial message. How many of you know how a help desk ticket is closed out? How is a help desk ticket closed out?
The ambulance closes it.
That's right. In other words, basically, you call them, they can't get you, it's closed and resolved. And that's so that they don't get in trouble. One proposal in some places has been that the CMIO should be running the help desk tickets and making sure they're actually resolved. Though they might not have anything else to do during the day.
The structure is 10 minutes, 10 minutes, 3 minutes, 3 minutes, 3 minutes.
Okay, so you did 10 and 10, you got 3 and 3.
All right, so I was reminded of my mom. You know, whenever something ails, whether it's say I stubbed my toe, I have a sore throat, or a headache, my mom tells me to go and drink some chamomile tea. And I'm telling Mom, one day they're going to arrest you for practicing medicine without a license. I think we have a problem with lawsuits as long as without a license.
You're always practicing informatics?
I think he's practicing informatics without a license. That's what I'm thinking.
I think he invented informatics.
All right, so I think I was worried about that you know, looking at the core competency, that you know, Ross would look at it and says, you know, man, there's lots of stuff in there that I don't quite know what it is, but the stuff that I'm familiar with is not in there. So while he was talking about, you know, all the things that I am that he was missing in there, I just made some markups on my list of items that were on the exam: safety, effectiveness, legal, ethical, and regulatory issue, quality and safety issue. I think the help desk falls into at least 2 of those. When it comes to dealing with the various dimensions of effective leadership, governance, negotiation, conflict management. I think I saw that on this slide somewhere. So, you know, those of you who really want to know that, I mean, the paper that Reed Gardner put together, and I want to remind you that those 2 papers about the core content for this clinical informatics curriculum, and the paper about what the fellowship, the training should be like. They were funded by the Robert Wood Johnson Foundation to the tune of about $300,000 in order to put the stakes in the ground and define this new specialty and help identify the things that should be in there. And this was by no means a complete list, absolutely not. And you know, you can't, within a period of 3 weekends where people are put together in a room, have a complete list.
But the intent of what was supposed to be covered in this core curriculum was very clear. And the committee that wrote the questions went along with the overall scope of what was supposed to be in this. And I think, I agree with Ross, those words were not in there, but those words were in the content as an intended piece that was supposed to be tested. So, and I also think, it's very important for us to realize what the target audience is. Not everybody who will take the clinical informatics board specialty exam will be a CMIO going forward. I think there's a large group of people who have interest in building clinical decision supports or improving the documentation system that they have, and this training will provide them with the skills to do better. I'm sorry? Time's up, okay.
I just want to leave it with one comment, Ross, and that is that if anybody thinks that medicine itself is autonomous, you have to get back to the reality that we're living in a world of ACOs and team sports, and that's how we practice every day. And that's how we need to practice informatics as well.
Are we done? Okay, so first disclaimer, I am on the group that is writing the questions for the exam. By the time I'm done, that may no longer be the case. But let's get started. We've heard these jokes about practicing medicine without a license, or practicing informatics without a license. But you have to realize that the folks who are taking this board exam are by definition part-time informaticians, right? They have to be practicing, they have to be keeping their other boards up, right? They only have to be doing 25% informatics for 3 years to qualify. So by definition, they're part-time informaticians. If you look at the planned accreditation, many of the programs aren't even requiring a master's, much less a doctorate. They're just requiring a certificate. So what we're doing is we're certifying the folks who by our own definition are not the most qualified in the field, but we're giving them an imprimatur. And what happens with professions? Professions are designed to keep other people out, right? I can't get board certified because I don't have another board certification. Nurses can't get certified. Biomedical engineers can't get certified. Radiologic physicists can't get certified. So we've sliced off one group and we've given them the magic keys to the kingdom and already said, and they're not the smartest ones in the kingdom. People are paying with their wallets, right? No, they're paying because they're afraid. This is already showing up in job descriptions. I had to tell our own HR department, don't take that out because board certification doesn't exist yet. You can't require it. So people are paying this money to keep their darn jobs, right? There is no demonstration of practice or skill like there is for a typical program. You don't have to show you implemented a system, right? All you have to do is do anything you can claim to be informatics and pass a 100-question test. How'd you feel if the guy cutting on your brain just said, well, I had to play with brains for 25% time and I passed the test? So, and we know that EHRs are powerful enough. When you do it wrong, you kill people. This is not mild medicine, right? So, if we're thinking about who we want to be doing this, right? This is like Obamacare, right? It's the law, it's going to happen, but it's a double-edged sword. And we're going to create an interesting paradox because there will not be enough people to do this job, right? I was in the room where the board directors were talking about standing up residencies, right? There were probably 3 folks in the room who said they'd actually done it, about 20 more who said they wanted to. They sent out a survey, or 50 who wanted to. Not one of them had more than 1 fellow a year. Okay, with 8,000 hospitals, we're not going to get by on producing 50 new people with this certification a year. So, but we're saying they're the most competent while we're, the NLM training program, right? The Cadillac doesn't qualify, okay? So all those NLM trained people, no, they can't take the boards. They won't qualify. So we're gonna have a very small group, and it's gonna create a problem where the people with the control don't have the knowledge.
Alright, so that's of course a tough act to follow. You guys should know, I'm also on the committee that wrote the question, and you know, because I was on the committee and I still had to take the board, Justin was my oral examiner, and let me tell you, I haven't been that scared in a long time. So having to follow him here is a tough act. So a couple things though, that first of all, there's one thing that I want to correct, because those people that were able to grandfather in and will be able to grandfather in for another 4 years, NLM fellowships are okay. Okay, so they are equivalent to fulfilling the requirements, and it's sufficient in order to be eligible to sit and be grandfathered into that. So that's one thing very important to point out.
Regardless of how far in the past the fellowship went?
Yes. The rule on the fellowship was that if it was part of the original 20 or 21.
Exactly.
That Amy has submitted to preventive medicine, they don't care how far back. What they needed to do was basically list what they think they covered and say it's pretty much like what we covered today. It doesn't matter.
That's right. So, and then I think it's at this point it's very important to try to point out this is the start of a new specialty, and we are doing an incredible job of identifying people that we think have the minimum required level of knowledge. That doesn't mean that they're all Justin Starnes of the world. These are people that have identified as somebody who requires fulfill a minimum set of qualifications, and thus are entitled to sit for the board exam, which they still then have to pass. You know, this is not a free pass into becoming a board certified subspecialist. So I think we will see, if you look at the numbers, this year more than 500 people have sat for it. If you look at numbers in other new subspecialties, we expect next year to have even more candidates sitting them, because the smart ones, they sit out this year and see what the questions were. Sorry, Joseph. And so they sit out the year and wait for the others tell you about what was on the exam, and then they take it. So we're expecting an even larger crowd this year, and then you are absolutely right. We will have to ramp up those fellowship programs if we want to fulfill the demand. But we're just starting out, and we have another 5 years of getting a whole bunch of people who are potentially eligible to get in there.
Okay, last one. So, first of all, I also have written questions for the exam. Not officially, since I couldn't, but a lot of people have told me and asked for help, especially on articles I wrote. Look, the focus is not the existence of the training or the exam. It's on the focus of the exam. I think it, and you know, I've not seen it, I'm the blind man in the elephant, but I do think that there is a lack, that there's insufficient focus on the nuance, on the floor ethnographic observation that makes systems work or not work. That there is never cookbook. The reason I showed the thousands of, literally tens of thousands of problems that somebody who's doing this needs to address is that that's the reality. There are up to 200 to 400 separate IT systems in the average hospital. Each connects to the EHR, each is a potential vulnerability, each is pretty special and sometimes unique. My last sort of points. There's an irony that this is the preventive medical board, because what the U.S. medical system is so focused on is the exact opposite of preventive medicine. It's on acute care. We really screw up royally